But I am going to pass it over to Q and let her introduce our keynote for today. I should just give you a few housekeeping tips. We will be offering, for those of you who need CEUs, we do ask that you fill out the evaluations that we will put on the chat right after each presentation is done. We're going to collate that with the information based on your registration and your time on Zoom today. And then we'll put those out to you via an email. They'll be coming from Department of Mental Health and or myself. We haven't decided how we're going to distribute them yet. I think that's what I have. We're going to have a question and answer period later on today to end the day at 1:45 to 2:45. I think that's the right time. I might have screwed that up. Nope, I got it right. And so we've collated all the questions from yesterday. We'll be putting them together today as well. And if we have time at the end of each presentation, we'll also take questions then. All right, Q, it's up to you.
All right, good morning, everyone. Welcome to day 2 of the MRSS conference. If you really enjoyed yesterday, then you have even more excitement coming today. As you see, we have a full agenda. And we're kicking it off with our keynote, Dr. Chris Morano, and he will be presenting on, I believe it's big little steps. It went away, so I couldn't see it. Hold on one second. Small steps, big changes, taking MRSS to the next level. And so we are going to have that presentation. And if you're excited like me, here's some information to get to know Dr. Chris Morano. Number one, before I do his bio, don't call him Christopher, it's too formal. And he has been a licensed psychologist for nearly 30 years and has been the director of the Emergency Mobile Mental Health Services for Milwaukee County Children and Families. And with this responsibility, it includes managing of inpatient care needs for high-risk youth, and he currently consults with local mental health agencies on the needs of children and families, along with the experience both performing the service and managing those who do. Dr. Morano has trained locally and nationally in community crisis intervention and has helped set up teams across the country and served as a consultant from Oakland, California to Buffalo, New York, so nationwide. And at this present moment, Dr. Morano is at the University of Maryland at Baltimore doing national trainings in the crisis intervention. And Dr. Morano has also worked in both inpatient psychiatric settings with adults and children and community mental health settings dedicated to the delivery of mental health services in the community. Dr. Morano is committed to helping systems develop successfully through community solutions and utilizing a continuum of care with formal and informal support to emphasize and make sure that things are less intensive, safe, and naturally occurring strategies happen. And Dr. Morano has an ongoing coaching collaboration with the state of Nevada and Ohio. Finally, Dr. Morano recently published a book on alternative ways of thinking about and helping children called Paleo Parenting. I love that. The Many Myths of Childhood Mental Illness. And with further ado, I pass it over to Dr. Morano. Thank you so much.
Thank you, Juanita. And most of my life is based on a true story, most of it. But here's a story that's absolutely true. A few years ago, I got a call from my boss, and he told me that there was a distraught father in our universe in Milwaukee who had called the local NBC affiliate and told them to show up at the children's court because he was going to bring a gun and he was going to make a spectacular scene and shoot a bunch of people. And I asked my boss a key question, a critical question. I thought at the time. And I asked him, well, has anyone talked to this man? And he said no. So I got the phone number from the gentleman's care coordinator. He was in our wraparound system. And I called him. And I went to his apartment. It was in a pretty complicated and complex neighborhood, let's put it that way. And I talked him out of bringing the gun to the children's court. And who's held a gun before? Raise your hand. I see a lot of hands going up. Who has seen a spiked bat with razors coming out of it and nails and screws? How many people have seen a spiked bat and touched it? He had a spiked bat next to his door, and I'll tell you what, the gun didn't make me as nervous as the spiked bat. You see one of those, you're going to get unsettled. We talked about that too. And what I'm not going to tell you, I'm going to tease you. Here's the teasing part right here. I'm going to tease you about what I did and how I went about that. But what I know is that people don't recover from trauma. They don't heal because of scripts or constant talk or techniques or strategies. They begin to heal because you'll get this. They begin to heal because they feel safe and seen. That's one of my topics for today. If you can go to the next slide, that would be great, Juanita or Laura. Thank you. We're going to talk about some other important, as I see it, over my years of doing this work, probably about 25 years in crisis intervention and mobile response, what I consider to be really important factors. And what I believe is that we can get really good at this. Some people might sort of get into this field and be naturally good at it. I really believe we can get so much better. And I'm going to talk about some ways in which I think we can go about doing that. Before I do, and thank you, Juanita, for that introduction. I'm Chris Morano. I hope you can see some of this. I have a PhD and an MS from UWM. I did run the MUTT for Wraparound Milwaukee WAM when we were at the BHD. That used to be the MHD, and it was the MHC at one point. And I was the PIO for the DMHTF in Milwaukee. And what does all that mean? Woo woo. Where would we be without all these acronyms, guys? I guess we would be SOL without all these acronyms. My mom told me when I got the degree, she said, Chris, PhD just means piled higher and deeper. And then she said, and don't make me tell you what MS means. A little bit about me. So I want to talk about some concepts today. I'm not going to give you a lot of direct, streamlined advice. I want to give you concepts, because if I give you concepts, you will use your own creativity and your own voice. If I give you all the step by step by step, it robs you. It doesn't allow you to give your own input into stuff. So I'm going to give you some concepts. I will talk about some strategies around the country that are working, and some important, I think, developments that we need to be looking at in Ohio. So Juanita, could you go to the next slide? That's me. Keep going fast. Can you click on that little thing there? Hey, there you guys are. You look like a Guns N' Roses concert. You guys are great. I don't see a lot of social distancing though right there. Thank you very much. Thank you, thank you. All right, next slide. Rick did some housekeeping. Generally, it's customary for the speaker to talk about where the bathrooms are. I think you know where those are in your house, but those are some colorful ones that I really like. Keep going, please. All right, so what works and where we should be going. This is a snapshot. I'm a little more organized than I let on. And here's some of the topics that I want to cover today. And I will throw a little bit of shame in there at a strategic point in this session. But I do want to get to how I got this gentleman to give up the idea of bringing a gun and how that all went. The importance of taking care of yourself. Sounds like a cliche now, but I'm really going to try to drive it home. And if we're really serious about trauma-informed care, then let's really do it. And if we are serious about trauma-informed care, especially the Bruce Perry version, then we've got to talk about including the whole family and dynamic strategies, and especially as alternatives or supplements to talk therapy. I want to talk briefly about a program that I'm familiar with that works with law enforcement. You want to hear a timely topic, there it is. We've got to partner with law enforcement these days. Everybody is aware that emergency rooms are getting populated, not just with people with a virus, but mental health challenges as well. CPTSD is complex PTSD. It's emerging as a topic and it needs to be discussed. And then we'll go to the end. Okay, Juanita or Laura.
Yep, it's
All
Laura.
right. Laura, hi, Laura.
Hi.
All right, I'll stop teasing you. Donald Meichenbaum, the founder of cognitive behavioral therapy, is fond of saying nothing happens without empathy. Nothing happens first without engagement. That's how healing starts. We can learn cognitive behavioral therapy. We can learn EMDR and all those fancy techniques. We've got to be able to help people in the room feel safe, like they can trust us, and like there's hope. And that's part of how I got through to this gentleman. He was distraught. I talked to him on the phone, and within about 15 minutes, he agreed to let me come to his house. And what I did was, without throwing my brothers and sisters in child welfare and in the court system under the bus, I didn't do that. I let him know that I could completely understand how exasperated he was and how upset he was that his children were taken away the night before and his wife was jailed. He got from me that I understood that and that it was okay with me. And so I validated him. And that was the beginning of our engagement and connection. He agreed to let me come to his house. I went by myself. I didn't bring police. I didn't bring any staff members. And I got inside his house where I first met the spiked bat. And he told me one of the things he was really upset about was that his son was in the Pinewood Derby in the Boy Scouts, you know, where they make little cars and they send them down to shoot. And he didn't get to do that because his kids were taken away the night before. So we went to his workshop. I didn't go in there and talk about guns. I didn't even mention the spiked bat. I walked into his house and we went, I saw his son's work and I saw what he had done and how proud he was, and we connected. So you can't go into someone's house with a clipboard and explain your team to them and then say, well, why am I here today? You can't do that. You've got to find a way in your own voice and your own style to engage with people. I will give some sort of more direct consultation or advice on how to do that when someone's very distraught in a moment, but you've got to do that. Laura? Safe and seen. This is my mantra these days. This is what families and youth need. If we're going to help them, they've got to feel safe and seen. It is a primary, foremost need for everybody. You don't go forward without it, or you go forward very tentatively and you go backwards. Laura? I really believe this. It's outrage is popular these days, but if you want to be in our field, if you want to take advantage of and get really good at the incredible opportunity that you have as an MRSS staff, doing mobile response in the community, going to people's homes when they're at their most vulnerable in their houses, where they sometimes reluctantly welcome you, what an incredible chance you have to be a healer. And part of that is how you present yourself. Part of that is, of course, how you control yourself as you walk into a room. And so you've got to learn, if you can, to underreact to almost everything. Sometimes you have to take action. I've done things where I had to be more direct, and you have to act as if you're going to be of help. You have to be able to internalize that, and that takes some work. There's a guy, I'll throw another name up here, and hopefully you'll be able to read it. He's important. His name is Stephen Porges with a P, Porges. Can you read that? Stephen Porges. He's out of Michigan. He talks a lot about polyvagal theory. Polyvagal theory is all about the connection between your heart and your brain and your breathing and how you appear to other people upon first brush, okay? It's critical that you control your face, your breathing, your tone of voice, all of that stuff if you're going to be effective at MRSS and you're going to help people when they're at their absolute most vulnerable and ferry them across a river of dread. You have to be able to control this stuff. Laura? The FBI's secret weapon, that's what I used on this guy. I listened to him, and everybody thinks they're a good listener. I'll challenge you on that one. We all got into this field because we want to help and heal, and we all think we're good listeners, but I can't tell you across the country how many teams I've been with where they believe the primary goal that they have is to get dialogue going. And that's important. You can't communicate without words, but you've got to use other strategies and other techniques, and you've actually got to be a good listener. You can't, I was with a staff person not long ago, and her goal was, I'm going to get this kid to talk to me. And she forgot the safe and seen part. So that's the key thing. All right, Laura. You know, when you get into a place, into a space with someone who's upset and distraught and can't see any way out, you've got to have at your disposal, first of all, some presence so that you can sit in that very terrifying space with them. You can sit in it with them without trying to wipe it away. That's our tendency. We want to take discomfort away, and I will posit that to a large extent because we feel uncomfortable. So we want to wipe it away. So I couldn't do that with this guy. I couldn't say things to him like, well, you've got a court hearing tomorrow. Maybe the judge will be favorable. Maybe he'll give you, I don't want to do that. I want to sit with him and I want to reflect with him so that he understands that I get it. And I had some of these sort of pat phrases, I call them back pocket phrases at my disposal. And it's really hard to do that, guys. If you want to connect with someone, if you want to help them feel safe and seen, you've got to sit with them in their pain and in their distress. And that is a really hard thing to do. Try it next time someone in your family or one of your friends is upset about losing a job or something like that. Try to sit with them for a moment without trying to erase it. It's really hard, but you got to be able to do it. Laura? I've sort of broken it down at another point to these sort of a bridge on how to build plank by plank that bridge from you to them so that they feel like they can get across that scary river. And you know, again, you can take some of this, put it in your own words, use it, not use it, discard it. But if someone's just a little bit upset, you know, you reflect to them, this is one of those bad days. If they tell you things like they feel like a burden, your ears should really perk up, and you should be able to deliver in a timely and genuine fashion some of the phrases on the right. This helps to make them feel safe and seen, and then they can begin a healing process. Again, a privilege that you have to be a part of that healing process. It's incredible, especially in MRSS. We don't always get it in other aspects of clinical care. In MRSS, people come to us when they're really in a bad place, and what an honor it is to try to help them. It's an incredible opportunity. Laura? You know, we want to avoid, again, these are ways to help people feel safe and seen and to connect with them. The ones on the right, avoid questions that lead to easy answers. You know, when someone asks you during the day, how are you? Of course, what do you say? I'm fine. You follow it up by saying, I'm really busy, right? Aren't we all? I'm busy. I'm really good. I'm busy. You should give statements to them that are more like open doors. You know, I'm glad you told me, thanks for stopping by. I appreciate you letting me in your house. And you use a tone that is welcoming and accepting. All right, Laura? Assessment tools do have their limits. And again, I want to encourage you when you first meet someone, whether it's a parent and a family or a kid by herself or himself or themselves in a school, on a street corner, to sort of, in an effort to engage, put away the clipboard, put away the checklist. I know that we hold hands with Medicaid and SAMHSA, and we have to have these things filled out. We've got to submit these things to our QA/QI people, to our outcome people. When you meet somebody, especially if they're in distress, try not to put it in front of you, even if it's on your lap, as a sort of a barrier to dialogue, okay? You can use it to broach subjects and all that stuff. You need it for safety planning, but first steps, when you walk in the room, when you're talking to somebody, try to have enough conversational skills, enough engagement skills to be able to reach out to them without having this thing in front of you. Laura? So here's the second part, and I'm not saying you all need to go into therapy. Here, Lassie clearly, and some of us are old enough to remember Lassie, Lassie clearly misinterprets what Timmy is saying, and Lassie goes into therapy before Lassie tries to help. I'm not saying you need to go into therapy before you try to help somebody. I am saying something. What do you think Lassie's saying there? He never takes me on walks anymore. The same old food every day. Lassie's complaining to the therapist. Anyway, but we do have to do some things differently. If you want to maximize your ability as a healer, Laura, you've got to deal with your own stuff. And again, I'm not saying you have to go into therapy, but you have to be present with people. You have to have enough balance in your life and enough healing that you can attend to somebody in the moment and stay in that space with them, especially early on in the early intervention parts. You have to be in the no contempt zone. You can't answer the phone with, hello, this is Mobile Response, you know, with a sort of dismissive tone. You can't have contempt for the very people you're trying to help. So that's another thing we'll get into shortly around trauma-informed care. But deal with your stuff, get yourself in a good place, and then do the work. If you get those things in the wrong order, shame on you. All right, next, Laura. And yes, of course, it's really hard on people. We learned that in the past year. I've known it for a while. I've been working from that vantage point for a long time. Go back, thank you. But since the lockdown and the pandemic, we really have heard a lot about first responders, people like us who are getting overwhelmed and need respite, need a break, that kind of stuff. And that's where leadership comes in, to help people be in the best place possible to help others. And I like this Richard Branson quote: if you take care of your employees, the clients will be just fine. Okay, if you really take the effort, and I don't mean train them all the time. Again, hopefully you're getting that message. It's not about getting them more training in a checklist or something like that. It's about something else that we'll get to. Laura? You've seen this one before, right? This little meme. It's got to start with you. There's a reason they tell you to put your mask on, your oxygen mask in the airplane first before you try to help somebody. And I'm telling you, if you can get to that place, you will be really good at this job, because it's a 6-week commitment on your part, and it's a critical timeline in the lives of many of these people. And if you can get compassion for yourself, you will exude it, you will give it off to other people, and they will feel it. Laura? Did you know this? Read that. And I'm not talking about toxic positivity. You know what that is, right? Toxic positivity. And I don't want to offend people, but I guess when you try to do things differently, you end up doing that. But You know, I like the good vibes only t-shirts, but you've got to actually address, and I dare say confront and handle the negative stuff in your life. I'm not talking about toxic positivity where you're always saying, it will get better, this too shall pass. I'm not talking about the cliches. I'm talking about when you do the actual work and you are able to, through gratitude and through discipline, be optimistic. You're going to live longer. You're going to be happier. Research has shown that. Richard Davidson, a guy from University of Wisconsin-Madison, is big on all this stuff. He's a researcher that takes a lot of pictures of people's brains to show this. Okay, Laura. All right, a little bit more shame. If you really want to do trauma-informed care, especially the Bruce Perry version, it's time to start doing that. Let's do it. Let's stop talking about it. Let's stop just putting it in our brochures and you know, acting as if we're doing it. Let's really do it right now. Okay, Laura? Here's part of it. If you really want to do trauma-informed care, you need to stop saying this, or at least stop saying it when I'm around. That'll make me feel better. I hear this a lot, even from mental health staff who are trained, even from mental health staff who are experienced. She is just being manipulative. He's doing it for attention. That's like saying your car is broken down on the side of the road. Doesn't tell you anything. And it's judgy, right? I'll say that. And again, here's one. He, she, they have to take responsibility for his, her, their behavior. That's an empty statement too, guys. Because if we're gonna do this, we're in it together, especially if it's a little kid. We wanna teach them responsibility, but we can't just absolve ourselves of our responsibility in the whole dynamic. It's a two-way street. And if Bruce Perry has shown us anything, it's that healing from trauma takes at least two people. It's the difference between giving someone a basketball and telling them to go shoot hoops to feel better versus let's go shoot together. Let's go shoot hoops together. There's the difference. All right. And of course, we're all very good at asking what happened to you, right? Instead of what's wrong with you. That's one of the key phrases these days in modern trauma-informed care. All right, next. I'm begging you, I just did that already. If you're in a position to help somebody, they need your help. You know, and they can't, someone who's drowning in a river is in no position to reach up and take your hand or give you their hand. If someone's drowning in a river and you're saying, give me your hand, you should be saying, take my hand, reaching down to them. All right. Next, Laura. If we're going to do this, we're going to do it together. There's a reason I put a really little person and two tall people in there. Laura? This is the shift you've got to do. And hopefully you're doing this right now, okay? Instead of this kid is giving us a hard time, this child is having a hard time. All right, this is a shift. If you can do this and make it so reflexive, then you've really made progress toward improving yourself as a healer in that 6-week period and with every family you encounter. Laura? Here's the big idea. I hope I actually typed it in, because if I didn't, boy, are we in trouble. There it is. This is why he, she, they are just being manipulative doesn't cut it. Because maladaptive behavior, whatever we call it, attention seeking or manipulation or whatever, comes from unmet needs. It's not just a need for attention. And knowing when people are at their most vulnerable and when they've been traumatized. Next slide, Laura. Most often, it's because of the bottom part of Maslow's hierarchy. Their need is for safety. Their need when they're being manipulative is for inclusion. It's for predictability. That is such a vital thing for kids. They need to know what's next because their brains are growing, they're firing off, they're reorganizing, and they want to know what's coming next so they can develop their prefrontal cortex. So usually the underlying need when someone is espousing at a staff meeting that they're just looking for attention, it's for safety. It's so that they don't feel forgotten, so that they don't feel alone. And that's how you've got to begin to think about them if you're going to get to the next level as a healer. Next, Laura. And remember, again, this is sort of part of trauma-informed care, curve normal. So many things that kids do is just simply a manifestation of their growth, of their testing limits, which they have to do, of their exploring the world. Even thoughts of death or suicide are pretty common, especially these days. I read a study not long ago that in Los Angeles, something like 70+% of kids 11 to 14 felt hopeless during the pandemic. Can you imagine that? When you're 11 and 12 and 13 and 14, you're supposed to be bounding with excitement and enthusiasm, exuberance. These kids, to a large extent, because of the pandemic, felt hopeless. So don't pathologize it, deal with it, help them with it, but try not to put it in a box and make it diagnostic because you'll be in a better place to help them move forward if you do. Next, Laura. This also takes us to, Laura, next one. The reason why I put 2 tall people and one little, as they say. If we're really going to do trauma-informed care, we've got to look at the family as a whole. And if there's a little person struggling, even a teenager who's maybe taller, they may emotionally be smaller. And if there's a caregiver in the situation, we can't just do individual psychotherapy with the kid. And I can tell you around the country, a lot of teams have a model where they split off the therapist in the dynamic and they do psychotherapy with the kid. And they forget that the parent is really the focal point and the fulcrum in this whole thing, the caregiver is. So remember that. If there's a really tall person in the thing and the smaller person, you really got to include that tall person in the fix. Okay, don't forget that. If you find yourself in a room with a little kid and you're trying to, leverage some change in them, it's not going to really have as much impact or stick unless you include the caregiver and you really strategize with them, because they're the key here. Next, Laura. Yeah, and it's Harvard is a school. It's closer to where you are than where I am. And there's some other information up there that talks about how important alternatives to just talk therapy, especially for little kids, are if we're going to help them become emotionally and physically, and those two things are inextricably tied, become healthier. Okay, the LINK program out of Texas Christian looked at some schools in the Southwest, and all they did was give the kids a lot of outdoor time. And what happened was their academics got better, their behavior got better, and they're trying to implement this in other places. Okay, next, Laura. One of my favorite guys, Bruce Perry is one founder of Trauma-Informed Care, probably associated with it the most, but Bessel van der Kolk wrote a book, The Body Keeps the Score. It was a New York Times bestseller not long ago. In that book, he talked about how are we going to get better at MRSS? We're going to do a little bit less talk with kids and more activity with them that helps them balance their brains out. He talked about in the book in 2001, the well-intentioned and well-meaning psychotherapists and psychiatrists in New York City and the greater New York area offered free psychotherapy for people who had been impacted by 9/11. And what they found was, I think they tracked down 300 people who were pretty close. And most of those people, I think in the book, Van der Kolk talks about 90% of the people wanted some physical redress, some physical correction, massage therapy, Reiki, something in their body that would help their body feel better because of the trauma that they had experienced. And that's where he started to really come up with the idea that your body keeps the score. And they didn't really take advantage of the free psychotherapy. They wanted something different, okay? These days, I'm hearing more and more and more from providers and others that weighted blankets for anxiety, because anxiety is the thing we're all going through these days, right? Especially with kids, a diagnosis du jour. So we've got to start thinking of what else could we do besides putting chemicals in them and doing talk therapy, equine therapy, the Milwaukee model. In Milwaukee, we got the state Medicaid and canonized by SAMHSA and Medicaid at the federal level to pay for equine therapy. How about that? In Michigan, I learned a couple of years ago when I was there that their Medicaid system is paying for rock climbing for kids. What a concept, okay? And kids feel better when they do a lot of this stuff. They really get, especially if they've been physically traumatized, they feel like they've got control of their bodies, which is vital. England and Canada, they're positioning themselves where physicians are going to be writing scripts that let people get into the museum based on a physician's prescription, all right? As a preventative kind of measure, even as a corrective kind of measure. What a concept, guys. We've got to get better at this stuff. It's partly my fault and old-timey timers like me who said that talk therapy was the solution to everything. It's partly my fault, okay? I'll own that. We're now learning that there are many other things that help people feel better psychologically, emotionally. Next, Laura. Yeah, partnering with law enforcement. I couldn't get through this without mentioning this. Yale is another university that is out near you, more closer to you guys. They've got a child studies center. And Milwaukee, basically, as I was just rounding out my career there, we were getting on board a partnership with the local Milwaukee Police Department to go out with them in an effort to see people in the community. And I've been doing training with Milwaukee Police since the year 2000. We finally got around to this. And these mental health law enforcement teams, now part of my old MUT team, is co-located in the police district with these officers, and they go out together. And they have drastically reduced the number of emergency detentions. That's what they call them in Wisconsin. I forget about Ohio. Drastically reduced the number of emergency detentions when the mental health and law enforcement teams go out together. They've cut it in the past 6 or 7 years by over 100%. Anyway, and when the mental health professional remains with the family for a 6-week or 8-week period, the emphasis is once again on helping the caregiver learn new skills, not solely on doing child therapy. And it's been really very much a boon to try to keep people out of the emergency room and trying to mitigate PTSD in kids. That's another thing that the Child Studies Center makes as their mission. How do you reduce the likelihood that the child will have post-traumatic stress? You work with the caregiver. Next, Laura. Yeah, there you go. Well, I lied. Okay, now you caught me. It was a 50% drop. I looked at the study and I reported on it. And now it's about a 50% drop, which is huge, guys, in emergency detentions. So we've got to get better at this. This is a theme in our country, in our culture, that has been prominent in the past year plus, and we can do it. My own dramatic, true story about going to the guy's house when he had the gun and all that. It's all a testament to the fact that we've got to get more involved with local police as they try to maintain order, and we try to help them and educate them with respect to mental health issues. Next, Laura. Just briefly, complex PTSD, CPTSD as it's called. And I got this from, I'm a member of the National Healthcare Providers in Psychology, National Register. I'm a member of the American Psychological Association, so I get a lot of information from those two organizations. And CPTSD is now emerging as an area of study and intervention. you can see, at least from the brief article that I took this from, PTSD is what we typically associate with post-traumatic stress. Single discrete episodes, a hurricane, an assault, that kind of stuff. CPTSD is now emerging as an area that's important: repeated exposure, personal trauma, especially in childhood. And the two, while they share some of the same response to traditional methods, CPTSD is distinct, they're saying now, with respect to how do we treat it, how do we recognize it, that kind of stuff. Next, Laura. So, and just again, briefly, some of the evidence-based therapies for PTSD include those, okay? And you can just take this away and search it and pull on these threads as you will. CPTSD, again, a new area of study, newish. Phase 1 in trying to help the person, surprise, help them to get safe and feel regulated. Phase 2, you can see, and again, reframing the narrative is vital. And then phase 3 is daily living and building relationships based on what you learn. And also, from the Journal of Psychiatric Research, more therapy is not necessarily better. And I know I've been sort of talking about that a bit this morning. Often targeted brief interventions are more helpful. And that's kind of what we do in MRSS. Again, just as an aside, one of the things we're finding with people who are struggling in the moment, especially kids, talking them through it doesn't very often help. We've got to remove them from the situation, get them busy, distract them. And this often helps to lower the intensity of suicidal thoughts, just changing the scene, getting them to a different place, changing the chemicals going through their brain and their body. That helps quite a bit. All right, next. For those of you who have been doing this for a year or so and feel like you really got a handle on it, spoiler alert, it takes a long time to get good at this stuff. And you really forget some of the important elements when you're in the moment. And the only way you remember them is to do it over and over and over and over. Malcolm Gladwell, a lot of you know him. He wrote a book, and in that book, he described how it takes 10,000 hours of coached practice to get really good at something. A lot of grit. 10,000 hours would be like as if you had 1,000 or 20 hours of clinical contact per week, which I don't think anybody's getting. That would mean over the course of 50 weeks, that would be 1,000 hours. So it would take you 10 years. If you had 20 years of face-to-face coached contact in doing this work, it would take you 10 years to get really good at it. I'm sure some of you arrive with some really good skills and good instinct and good practice and good supervision. To do MRSS effectively, it's going to take a while. Next, Laura. This is one of my favorite little things. You're not a therapist. You do therapeutic things, guys. You really do. You are a healer. You're a foster therapist, because you're going to take someone when they're at their most vulnerable, and you're going to get them across that river of dread and hand them off to someone else on the other side safely, right? It's kind of like being a foster parent. You're not going to see it all the way through. That's where this concept comes from. Maybe you will. Maybe you'll do that really effective intervention in 4 to 6 weeks and things will be really good. But you are a healer. You're a supporter. You're a connector to that other side of that scary place. All right. And this is the valuable opportunity you have. You're there in their most vulnerable, important moments. I can't tell you how many people I've talked to, even recently in Ohio, who said, I got through to this kid, which takes many different forms. And they work with families and parents and kids who don't trust therapists. They've had bad experiences with therapists, and MRSS staff in Ohio are somehow able to give them a corrective emotional experience. They're able to show them maybe one little square of time when a therapist is effective, is present, and makes them feel safe and seen. And that's invaluable. Next, Laura. I was working in the South Bronx, which is different than Ohio, not too terribly long ago. And Kadiana took me around after the day of training, and we went around to the different spots in the South Bronx. It was July, it was 90 and humid. And I'm not kidding, and I'm not being facetious or sarcastic. Just about every corner had a methadone clinic on one side and a church on the other side. These were people who were extremely traumatized and very needy. And she said, you know, Chris, it was in the Bronx. I used to live in this neighborhood and I had to leave. It's just too depressing. And I said, tell me more. And she said, I get on the train from Brooklyn now, and as I approach the South Bronx and I get near my old neighborhood, I just have this overwhelming sense of dread and hopelessness. And she said, I don't know what we can do to turn this place around. And I said, Kadiana, try doing one thing for one family and one kid. And I reminded her that Helen Keller once said, when I was young, I thought my chief responsibility was to do grand and noble things. Then I realized as I grew that my chief duty was to do a small thing every day nobly. One small thing. That's what Kadiana began to focus on, helping one family. You may not help the whole world, but if you help one kid, that helps the world for that kid or that family. So do one small thing nobly. Next slide, Laura. Some of you are going to do, you're going to go to law school. You might go on to become an administrator or something else. But, and you'll argue at those times about, doing the homework, or you might argue about getting you didn't get your vacation that you wanted from the boss, or your office is in the wrong place, and you'll be upset about that. Well, guess what? Remember these days when you're helping families, and you help that one child who had an extra spark in her eye when you were with her. Remember these days, because these are the days that matter. These are the days that count. And do this as long as you can. And I want to tell you that one of the topics that we talk about is hiring, and it's hard to hire people. I think that the way that you build a sustaining and resilient and really good MRSS team and become a really good staff, it's not through compliance and carrots and sticks. If you're out there, supervisors, trying to get people to stay, it's by inspiring them, helping them to see this incredible work that we could do, and understanding their motivation for doing it. That's how you get to be really good at this. So do this as long as you can. Thanks, everybody.
Thank you so much for your presentation. We're going to look and see if there's some questions in the chat box. It looks like people are speechless, and now they're saying awesome presentation. Everyone's saying awesome. Thank you so much. And while things are rolling in, folks might need some time. I wanted to say that you have very nice tidbits all throughout for folks to carry with them and be mindful of when doing this work. One of my favorite pieces that you said was to just sit in it with them and don't try to wipe it away. Oh, right. That was good. That was good. Because we try to go in there with the paper towels and the towels, and they're trying to get to know the texture of their mess and their life and everything. So that's not for us to clean up.
Thanks, Juanita. I'm reminded, it really hit me in the face. I was sitting with a friend on a couch, and she had lost her job a few years ago, and she was crying and upset. And so we were close enough. I was rubbing her neck, and I sang those things to her that we all say when someone's in distress and they're close to us. It'll get better. You'll find another job, right? And she looked at me like, you just don't get it. Right? That's not where she was at. She wasn't thinking, I'll get another job, it'll pass. No, she was in a really dark place, and I had to learn how to sit with her, right?
Yeah, that's a great point. Like, just sit with me. I'm not worried about better right now. I'm feeling this. Folks are saying, always great. Thank you for the reminder to care for ourselves and our team members while doing this challenging work.
Can I jump in, Juanita? Because there's at least a couple of teams that I know of that have now operationalized self-care. By that, I mean they built it into their performance reviews. And the team here in Vegas now has a Zen room and a Zen garden that they can go to regroup and recoup. Another team has literally put it into their performance review. Not that they're going to get extra points, but just at least as a jumping off point, as a reminder, have you done your self-care this week? You know, and what do you need to begin to do that on a more consistent basis? So if we can start doing that, then people will really, I think, begin to embrace this.
Hey, Chris.
Yeah, Rick.
You know, I think, you know, I love the presentation, first of all, and thank you very much. I think part of this is, you know, also what gets to me is it's not only self-care, but it's also respect for the work that we do from others. And, you know, I never hear the phrase, thank you for your service to mental health professionals.
Yeah.
And I think we need to change the culture of how we are viewed as well in the larger system, so that folks appreciate and respect what we do, because I think we need to hear that as well.
I agree, Rick. And that really helps people to sustain themselves. It really gets people to continue to do the work, to be more resilient. We have to hear from our supervisors out there when we do a good job. And I was in Milwaukee last week actually, and my staff actually had a small gathering where they didn't throw rotten tomatoes at me. They told me, you know, one of the things we really appreciate about what you did was that you took care of the people who take care of people. And I said, that's it. That's what I was going for. And I had 25 staff. So I got to know them individually. I made sure that they were recognized and validated for what they did, because this work is not easy. This work is tough.
I have one question for you. So,
Yeah.
you know, you've been in this business for a long time, and you've watched mobile crisis hotlines evolve to mobile crisis to MRSS. If you had your crystal ball, what's the next evolution for doing MRSS and mobile crisis?
Well, you know, I can't help but project where I want it to go, and I want it to evolve into making sure that we do trauma-informed care and that we help families organically in their own communities. When you do a safety plan, you should put the people right next to the child and the family at the top of the plan, and the mental health professionals and the police toward the bottom. So what I would like to see this evolve into is truly a community-based and community-supported and embraced enterprise, where families, naturally occurring supports in the community are the ones that really rally around the kid and take care of this kid. Because we're gone. We might spend 2 hours with the family out of 168 hours in a week. And to quote a supervisor of mine from the University of Rochester Medical Center, therapy is it's a piss in the ocean. So that the families and the communities around these kids have to be the ones that take the ownership of the issues. That's what I would like to see. Where we really truly do that. And also, again, the partnership with law enforcement is vital as that conflict roils throughout our country. In the mental health arena, we can really be of help in assisting people who are in extreme distress, who are encountered by law enforcement. I'd really like to see that too. I guess the third thing would be, Rick, to really embrace alternative approaches to helping kids and families feel better, this kind of stuff that we talked about, from rock climbing to dance therapy to everything. I really want to see us embrace that more.
Thank you. And we have one question in the chat for you. How would you respond? Sorry, Q. How would you respond to a parent who says, I'm tired of being resilient?
I would definitely reflect that and validate that parent. And, you know, immediately go to one of my back pocket phrases, like, that must be exhausting at times to try to care for this child. That would be my first response. You must be exhausted sometimes to try to care for this child. And it's understandable that you would be really tired of this whole thing and want to just walk away sometimes. And I'm not afraid to say things like that. You know, you must feel like you want to walk away sometimes. And then you'd get a big nod, and you might even get tears from that. And then we would, to talk about planning for that, after we did the engagement and the validation, I would really look into what respite options are there for a parent, because I guess a fourth thing, Rick, is we've got to have respite. That helps for everybody to get a break. It might even help the child too. So what naturally occurring respite options are there for that parent after you validated what they are saying? You don't say things, well, you can't give up. You're their parent. You can't give up. Don't say stuff like that. No. You say the things that I said, I think, in validating. Then you talk about realistic, strategic problem solving. What options do you have? Even if it's just for a few hours in a day. Okay.
Love it. Love it. We have posted the SurveyMonkey evaluation for those of you needing CEUs in the chat, session 7. Because I'm talking, I guess I'll transfer
Hey,
over.
you took over. I was like, all right.
I'm sorry, Q, you finish. You finish, go.
Oh no, you're fine. You were doing great. As Rick was saying, we want to thank the presenter, of course. Thank you so much, Dr. Marano. And as Rick said, that the SurveyMonkey and the link for CEUs for each session is being posted in the chat box. And that is pretty much it. So thank you all so much for coming for the first session.
Juanita, can I just say thank you for the opportunity for me to give you, at least from my qualitative perspective, my years of experience and around the country and around the world actually doing some of this stuff. I appreciate the opportunity. Thank you.
Thank you.